Hang on to this sheet because I'm going to ask you guys questions as we do it. In practice, we're finding that a lot of our nurses are not ready for practice. Like they're not applying the knowledge when they get out there in the workforce. So my job, as I see it, is to not only help you to understand and navigate the content, but to make you ready for practice so that you actually know what to do when you have this kind of patient or that you come across different kind of issues. So you can't just think about the stuff, you have to think about how you're going to apply it. And it's nice to see your smiles. So I'm a little nervous about taking my mask off because I have my youngest child, my son, and his bride are due to be induced on Thursday. Hi.
So I'm in break, and I was going to come talk about BSN, whenever you can.
Oh, come on in, that's fine. Okay. So anyways, my son Kevin is going to have an induction on Thursday, their first child, little boy, hence the blue footprint on this hand. And then my daughter is due to have her third in May, and that's my pink footprint on this finger. So I was a little surprised we had masks come off, but I trust that everybody's following the protocols. And I just think it's easy for you to ready, and for me to get to know you and see your faces, because it's been so hard to even remember a face because we have like eyeball and hair. So she's going to come in and talk to you about the BSN program, I think. And it'll give me a second to get another activity ready for you, so that's fine. She'll make. Oh, where'd she go? But this will be my sixth grandson, and my daughter Guys, hello. We're going to give our attention to Ian Marie, who's going to discuss the BSN program to you.
Very new to me. Wow, I feel like I'm on, you're in China or something. So I'm Marie Canelli. I'm the Assistant Director for Academic Advising as well as the RN BSN Academic Advisor. And I'm here to talk to you all about BSN. My colleague Vanell White will be joining me in a few minutes. I have some laboratory swag up here, stickers, pens, and if you apply, you get one. Just kidding, you can have one without even applying. Okay, so some of you have already met with me, but those of you who haven't, I'm just here to encourage you to consider staying at Laborate for your BSN program. Laborate College to BSN program is 49 credits. The transition from associates to BSN is quite simple. You don't have to pay the application fee. You just fill out the alumni. I don't have the website up, I apologize. But go to the main website and you just hit apply, and then you fill out the alumni form. I'm hoping a lot of you do stay at the college and consider doing your BSN here. Depending on the number of arts and science courses that might transfer in, that will determine how long the program takes. Does anybody in this room have a prior bachelor or associate degree? Those of you who do might have a lot of BSN arts and science transfer credits, in which case then you would just do the nursing professional classes. The first step after you apply, you'll get an email from the admissions department, and the email will say, sign up for an accepted student day with Anne Marie. Yours truly, and I'm wearing green. Happy St. Patrick's Day, by the way, to everyone. Very glad you're here on campus. So after you apply and you attend the accepted student day, then you are able to register for classes. If you are staying on and you like to start classes in the summer, you can absolutely do that. Or you can start in the fall, you can take a couple semesters off. You do not have to be licensed to start BSN arts and science courses. You only have to be licensed to do the nursing professional classes. My colleague Ben Elk is giving out really cool pens. These are for future BSN students. They have a flashlight on them. Right, okay, regardless, you can still have a pen with a flashlight even if you don't stay at library college, but we hope you do. And I'll be one more second, then I promise. I know your faculty member is waiting patiently for me. So everybody, there are also business cards up here with my name on them, as well as Jim. Jim is the admissions counselor. We can both answer generic BSN questions. Anybody have any questions in general about our BSN program at Library College? I think I've met with a handful of you already, funny enough. Go ahead.
The scholarships that we applied through, like, under the ASN program, do those still apply with the BSN?
Great question. So scholarships. So years ago they had this alumni discount for associate level students that continue on to get their bachelor's. We don't do that anymore. However, we lowered the cost of our credits. I should have told you that actually. We lowered the cost of our credits to be competitive with SNHU. You've all seen those commercials on TV. Don't go there. Just kidding. It's a good school. We're competitive with SNHU, UMass Boston, and Regis. So we are $350 a credit, and I want to answer your question in 1 second. I feel like a politician avoiding the question. We are $350 a credit. Most courses are 3 credits. So the average BSN class is $1,050. There are 16 classes in the program. As I said, if you have a prior degree, you might have some transfer credits. We'll talk about that after you've been accepted. To answer your question, so the alumni discount doesn't apply anymore, or the alumni scholarship, because we've lowered the cost per credit. However, outside scholarships can be applied towards the bachelor's program. You can continue on with financial aid if you use the FAFSA every year, providing you haven't used it all up during your associate degree. So other scholarships do apply, just not the alumni discounts. Is that kind of what you were asking? Okay. Seriously, you seem kind of interested. I don't mean to put you on the spot. So what's your talent today? Just feel like I'm on, Fidel, get up here. So let me do some stand-up, just kidding. So I'll do BSN stand-up. Any other BSN questions? This is the school for you. Oh, so awesome. Hi. I think I'm using the microphone too long. I think the battery's died. So, BSN, real quickly, why do you want to stay at Library College? I feel like it's a trivia question. Because A, the transition is super easy. B, half the faculty overlap from associate to BSN, so you're going to know a lot of the faculty. Faculty are great. I also forgot to mention the BSN is 100% online. So you will not be coming to campus. As much fun as this has been today, and I love seeing people in real life from 2 years of being stuck at home. The BSN program is 100% online, so it's flexible around people's schedules. Please just schedule a meeting with me, and I will answer any more specific questions. I think a lot of you have already met with me, but is there anybody that has any other questions? Okay, so every time you use that pen that Manal handed out, think, I gotta go and apply for the BSN program. Okay, I'll be in Vegas next week, just kidding.
Also, guys, we have wristbands up here. We have swag. We have swag. Okay, please apply. All right. I talked a little bit. I felt like, you know, my jokes were going down. All right. All right, gang, here's my card. Thank you. I love you guys.
No, so there's, I only have to take out of it, and I think I got it. But I know that I got it, because I counted up, there's like a sheet that it'll show you, go to,
and just be doing it online for maybe 1 or 2 courses a semester. It's a very different animal than doing your pre-lis and show like this event. And it's something that you can work towards gradually at your own pace. And once you get it, your pay will actually increase. You have more opportunities open to you where you can work in your facilities. So I know right now you probably also love like home now. But I do want you to think about not waiting too long, okay? Some people just like jump right in and get it done. But, and if you do have a BSN, I will say this, if you have a bachelor's and another concentration, show me your hands that you do, don't waste your time on a BSN, go for an MSN. So you can go for an MSN with a prior bachelor's degree in something else, okay? So look into those programs. More bang for your buck. All right, so my lovely battery assistant will be coming back. As you can see, I am half Swedish, a little bit of Irish, mostly Norwegian, but I had to represent in a slight way that I could. We're just going to change these up so we don't run into problems. For any of you that are celebrating today, though, just be safe this weekend. I know that my oldest son lives in South Boston, and they're excited for the parade back. Is anybody going? It is crazy. I'm avoiding him as well. But they get very excited about it. They were really bummed with that. Yeah. We are all ladies at my house. Right, so without further ado, let's take this back and get rolling. So, how'd you guys feel about the last test? Everybody's doing good? Alright, so this is a complex thing, but I'm going to spell it out. I'm going to try to get you to open your eyes to what's really important. But I do need you to follow along and to be participatory. And then when we're done with this, you guys are going to go to the Socrates site and you're going to do the quiz that Stephanie has done. And then we're going to review it. I'm going to bring it up because I think it's important to talk about those. Because that will be like studying for the test. This thing is moving fast today. All right. So concept definitions. Make sure you guys know these. And specifically, let's talk about the definition of the fluid and electrolyte concept. It's the process of regulating extracellular fluid volume, body fluid osmolality, and plasma concentrations of electrolytes. And the fluid, of course, is the water and substances dissolved and suspended in it. And our electrolytes are all about this class, all about this test, really. They're the substances that charge particle ions when placed in water, the helium and the anions that we need to have proper function of our muscles, our heart, so they're already coming into play here. If I don't trip over the stubble wire, it'll be in here. So, osmolality, the degree of concentration. This is think about your diabetes insipidus people. People with hydration balance problems, and when they get dehydrated or overload, this is when this comes into play. The solutes and the glucose and the sodium are running wild here. What about oliguria? What is that? Is that a problem? Yeah, because in a whole 24-hour period, we're putting out 400 mLs. What should we put out in 24 hours?
30.
Do the math. 30 cc's an hour for 24 hours. Where does that come to? Right, so we're in a deficit here. These are these patients that they're starting to put out less and less urine. What labs would you go and check if you had a patient putting out less than 424 hours? Yeah. What about the source? You gotta go bladder scan them. You're gonna check their INOs to see maybe this wasn't recorded. Maybe they were incontinent. Maybe somebody got up on their own and it wasn't recorded. But you need to do an investigation. Anuria. Where do you see this? So anytime there's an A before a word, like when we say afebrile, and we're all fancy, instead of saying they don't have a fever, A means without. So anuria is without urine. And I say that, but I will say to you, occasionally these patients can squeak out a little tiny bit of what doesn't look like urine. It's like Coca-Cola, very, very dark. Okay? But I want you to be aware that sometimes you will see a little tiny output from them. But mostly it's in urine. And you would state that in your notes or in your report. And then polyuria. When do we see that? You're remembering, yes, in your diabetes insipidus. And so normally we put out between 1 to 2 liters of fluid a day, normally, you or I. Especially now that we have the masks off, I think we'll be drinking again like we should. I think we all kind of went into AKI during the pandemic because we couldn't drink. But when people are putting out greater than 2.5 liters a day, that's when we call them polyuria. They're usually 2.5 to 3 liters a day. And dysuria, has anybody ever had that? Right, so that's painful urination. And what about hematuria? When do you see that? What is it? Right, can we see it? Sometimes, but usually it's microscopic when we see it in the UA. Okay, and then venous clearance. We're going to talk about this more, but this is when we're trying to identify the ability of the kidneys to actually clear those substances from the plasma, specifically creatinine. And we want to do a creatinine clearance. We typically do that in a 24-hour urine collection. And we're going to review that again in a little bit. So the scope is always something that we have to discuss, and I think it's relevant, especially with this. So your fluid volume deficits, think about your patients that have really dry lips, their pulse is fast, their blood pressure is low. These are patients that we worry about, correct? They're not perfusion. The perfusion can become an issue as we head into fluid volume excess with GVG and edema on the other end of the spectrum. And they'll have those bounding pulses that we'll feel, and they'll have an increase in blood pressure because their heart has to work hard to get the fluid. So this spot in the middle, this evolemia, embolifying, where we want to be. It is having normal amounts of body fluid. So our electrolytes, we have low electrolytes, know your norms, and having them low can be a problem, and having them be elevated can be a problem. And we will discuss that, but you want our electrolytes to fall in the normal category. And I will say this, many hospitals, different facilities have different ranges in their labs. When we give you a test question, it'll be so beyond normal that you will know it's the abnormal finding. Because sometimes I say 3.5 to 5 or 3.5 to 5.5 for potassium. So we would never give you like a 5.7 or, you know what I mean, something weird. We give you something that would be stand out to you as something wrong, or 2. So you want your electrolytes to be on target. To review them, if you need to be more clear, then 76A is your Exemplar nursing interventions, collaborative therapies. Make sure you check that out. So I'm going to play you a brief video that I think is cool, because I don't want to review your A&P. It's really brief. If it works. The tubules sense compounds the body doesn't need, like urea, left over from the challenges is not, having the time to go over, your A&Ps. I know it's been a while for some of you and pathophysiology. And I think with these kinds of courses, and classes specifically, it's important to know, the pathophysiology a little bit more, so dig down a little deeper, and so we try to provide it when we can. So go over all the functions of the kidney that we just discussed in this video. Realize that there are risk factors for impaired elimination. For instance, we know that as we get older, we have a less of a desire to drink. I also want you to check those videos out on Brightspace about the different reasons and about it. There's specific videos that I think you would find helpful. But so when we get older, we have a less of a desire to drink, and it affects individuals that have dementia. We worry about those individuals that have cognitive problems. And then, of course, babies are 100% dependent on their parents for hydration. And if their parents are not doing well, or if they're a PPD, or if they're not engaged, and we all know what I'm talking about, babies can dehydrate very quickly, as can elders. With babies, we see it in a depressed fontanelle, and the top of the head sinks in. But they, in your practice, will be the most friable patients. When an elder gets dehydrated or a baby gets dehydrated, it's very, very scary because we need to act quickly. And we're seeing a lot of people actually in Ukraine dying of dehydration because we can't get water to them. So ethnicity also, with Blacks and Hispanics, especially males, having more problems with non-modifiable ethnicity aspect of having kidney impairments or risk for elimination issues. And we'll talk about that more. On the modifiable end of things, obviously, if we can change people's behaviors, to get them to eat healthy and to increase exercise, we might be able to dash the heart disease, the hypertension, the heart failure, and coronary artery disease if we can. And diabetes, we know, is something that affects many. So it's so important that when we have a diabetic, get glycemic control. And teaching them the best way to stand, and let them know that there's a correlation with uncontrolled diabetes and liver and kidney impairment as they go forward. We want to keep the A1C under 7 ideally, and now they're bringing it down to even 6. I would like to ask you guys to hold off on doing that quiz because I want you to pay attention, and we will do that together in a little bit. I'll give you time for that. So unhealthy lifestyles such as dieting, exercise, you want to increase their exercise, smoking cessation, and decreasing alcohol intake. Obviously, major trauma can cause, or any surgery can cause a risk for hypovolemia. And I had stated during, did any of you in my Louisa this week? Anybody come to our Louisa on? No, I'm going to be there tomorrow, but the one for the other day we talked about how surgery, when we get post-op patients, it's really imperative that we make sure they have a good running IV. This comes to practice because they will sometimes disconnect the IV and throw them upstairs with you. You need to make sure you check the orders, and the orders will be run, IV fluids at 100, 125 overnight until the patient can take in orally 450 or more, and that they're voiding because they've been in NPO before surgery, 24 hours, right, from midnight on, and then they've been in the OR not eating, and so now they come to you, their kidneys are screaming if they have not got a lot intraoperatively. And so it's important if they lose IV access for any reason and transport to the bed. I've had young nurses come to me and say, a patient just got back from their total hip surgery and their IV came loose, but they said they were fusing it. I said, well, they just came back from the OR. Did you explain to them that it will hurt the kidneys? Oh, well, they just told me they don't want it. And if I go in and if I would explain to them, I realize you don't want an IV, nobody likes to be stuck with a needle, I've done a lot, can I give it a try? It's really important to keep the IV fluids going overnight to protect your kidneys. And providing education is important, because if you don't get the IV in, you got to document that you need an attempt to, and that you notify the doctor. Because we've had patients go into acute kidney injury just because they did not have IV fluids overnight after surgery. So that is an avoidable thing. Major traumas obviously can hurt the kidneys. Stress and any pharmacological treatments, specifically what kinds of things do we worry about that can hurt the kidneys? NSAIDs, diuretics, you're all correct, ACE inhibitors. So some things that we actually do to help us can sometimes hurt us. So whether it be for treating infection or heart issues, so we need to be mindful of that. Okay, so make sure you're taking a good history on your patients. Ask them what their perception of their health is. Remember, that's my big thing, like don't walk in thinking they're a train wreck. Sometimes you walk in and they think they're fine. They don't understand what's going on. Either it hasn't been explained to them or they're just not in the acceptance of it. So I always like to say, so how are you feeling? How do you think things are going? You want to find out past medical history that would be significant. Any lifestyle habits that are important, like do they drink only Diet Coke all day long, from sun up to sundown? Because what does that have a lot of? Not just caffeine, what does it have? Phosphorus, which just goes in and sucks the calcium right out of your bones. That's why we have people that have drank Diet Coke from morning to night. And I have a kid Diet Coke in my bed, not passing judgment. It was a big eye-opener for me to understand that dark-colored sodas have very high phosphorus levels. So if you were a home nurse and you went in to check the home of a diabetic and you saw a big 2-liter bottle of a dark-colored soda beside them, you should have red flags go off and you have to have an education point, okay? You want to ask them if they're having toiling trip issues. Are they having nocturia? What does that mean? They get up in the middle of the night. So maybe they are getting up in the middle of the night, so not picking up, right? Because we do that. I know my mother-in-law was like, oh, I can't drink. I will have to go in the middle of church. So she would never drink all morning because she'd have to go. And she wouldn't take her diuretic because she'd have to feed her in church. Everybody has their reasons for why they do what they do. But the important thing is that we provide them with education and maybe a plan for how to address it. Like maybe, okay, if you need to go to the arena and you don't want to take your diuretic, that's okay, and say one for me. But when you come home, you got to really start drinking and drink water. This is how much you need to drink by the end of the day and lay off the soda. It's just really important to identify. People kind of keep secrets, like if they're having incontinence or if they may be embarrassed that they're having some stress incontinence or difficulty voiding. Men especially seem to have a hard time telling you that their stream is not what it used to be. And that is something important for us to identify. I used to have one urologist who come in and say, so, can you put out a fire across the street? That's how guys talk to each other, and he'd be like, we're all ain't what it used to be. But it's important that we find out, because if they're having that stop, dribbling, unable to maintain a stream, then they're having a problem with emptying. And sometimes we have to be a little investigative in how to get that information out. Sometimes it's hard, and sometimes it's uncomfortable for us to ask those questions. You have to get into your zone where you are comfortable. Okay, and then your examination. What's the mental status like? Checking them for tenting on their skin. These are all things, as I'm thinking of my EPIC documentation, I'm checking. I'm going to review their labs. I'm going to listen to their heart. I'm going to check their blood pressure, see where it is against their normal. Like I said, their elimination patterns. Do I appreciate any bladder distension? My daughter she's a nurse practitioner, she had a gentleman come into the office 2 weeks ago, and she's like, wow, it looked like he was pregnant. She's like, he lay down on the table, and she felt so bad. He was a World War II veteran, and his wife said he's been crying for days. She said it was so hard, she felt like it was a mass. Did not have an ultrasound at the office, so she had to send him to the hospital. They took off over 2,000 liters of urine. So it came out in the emergency room that he's been having problems with emptying, just peeing a little bit during the day, but meanwhile everything backed up into his kidneys, got pyelonephritis. So these are important things that we check, like that distension. Is there any tenderness? Where do we check for kidney tenderness? Blank pain. How about skin assessment? What is something that I know that occurs with, who knows and works with dialysis patients? Anybody? Anybody have a family member with dialysis in their life? So, what would you say that one thing about their skin that they complain about? Dry and itchy, right? They're the ones that got the ruler going. They got the scratching thing going all the time. So what do you think can happen with that? Infection, breakdown, right? So one of the creams that work really well, and we typically order it in the hospital, is called Sarna cream. And you can ask for it and pharmacy will send it up. And it helps with quelling that itch. You can also get Benadryl for your patients or Atarax. You want to help them be comfortable because we don't want them itching excessively. Okay, Sarna, S-A-R-N-A. Just this for you to know in practice. But watch their skin because we do tend to have issues with that. And then diagnostic tests. Make sure you guys know, you're seniors now. You should know what a UA is, and you should know that if it comes back abnormal, it's going to reflex for culture. And why do we culture it? Because we want to know specifically what would be the most effective antibiotic, right? We want to find what it's sensitive to. Because why give somebody a whole round of a broad spectrum and it will respond to Catholics, so exploring. So that's why we want to make sure of that. Specific gravity, know your normal, and then your osmolality. And then just renal function tests. Understand that we might do KUBs, that's just an x-ray of the belly to see if there's any overt blockages we can see. And then ultrasounds, you guys will be doing bladder scans, but we can actually send them for ultrasounds to see the size and function of their kidneys. My dad was a dialysis patient, he had one very, very small kidney and one that was more functioning, and we found that out later in life. But I'm constantly, and you will constantly have orders for post-void residual scans. What does that mean? One person tell me, what does that mean? Yes. So specifically, after that patient pees, a couple times a day, once they pee, you get right in there with that bladder scan, you tell the patient, the doctors ordered a post-void residual. We just want to check to make sure that your bladder is emptying completely after you void. So can you please call us when you pee so that we can see if there's anything left in your bladder. And so it's just what it is. You go in there and you're scanning their belly after they pee, and back to bed. It's just gel, put it on it. Who's done it? Right? It's not invasive, it doesn't hurt. Tell them it's cold. And you can determine if there's urine still in their bladder, and then tell your nurse, because we have to document it, and you guys will be documenting. Post-void residual, there's an actual spot for it in Epic, and the doctors will come looking for it. And if they're like less than 200, it's not such an issue, but if they're attaining 400 or 500, what can happen? If every time they go and pee, if you guys went to pee, and you came back and I scanned your bladder and there's still 500 cc's of urine in your bladder, what do you think is going to happen? Well, it could be fluid overload if it was excessive, but I'm thinking more stasis, murk, yucky, infection. Yes, and it's stasis, so it's yucky, it's like swamp water. Okay? And then just know with cystoscopy and angiography, we do use dyes. So what will you be asking your patient about? Gel-based allergies, exactly. That would be contraindicated. Also the geograph will get into that. So let's just quickly go through this because this is what we call an unfolding case study. It helps you to answer the questions that I put in the slideshow. Okay? So Ms. J is a 63-year-old woman who was admitted directly to the medical unit after visiting her healthcare provider because of shortness of breath and increased swelling at her ankles and calves. She is being admitted with a diagnosis of chronic kidney disease. Ms. J states that her symptoms have become worse over the past 2 to 3 months, and that she uses the bathroom less often and urinates in small amounts. Her medical history includes hypertension, coronary artery disease, type 2 diabetes, glomerulonephritis. How do we get that? Anybody know? Has anybody struggled with, oh, I got a sore throat, I'm not gonna go get a culture. Undiagnosed strep being untreated can turn into glomerulonephritis. And look it up, it's a bad day. An appendectomy at age 28, cataract surgery in both eyes. So we know she's incurred some damage from that glomerulonephritis. She has hypertension. She has coronary artery disease, type 2 diabetes. She should be ringing off a lot of red bells in your mind when you're thinking about her kidneys. 4 pregnancies with healthy births, and she has GERD, controlled with over-the-counter Ranitidine. Her vital signs on admission are 160 over 96. Is that good? That's high. And she has hypertension. Heart rate of 88. Yeah. Okay. Respirations. Where are those? Those are on the high side. And her temp is normal, or she's 85 per annum. Why can't we just say her temp? Oxygen sats are 88 though. Am I concerned? Not through air. So the patient is replaced on oxygen 2 liters by a nasal cannula. You can do that. And following the labs have been ordered, serum electrolytes, kidney function, complete blood count, urinalysis, and a 24-hour collection for determining creatinine clearance has been ordered. So these are the labs that you need to know the norms of. Okay, very important. Make sure you understand that. Everybody freaks out about acid-base balance, but what I will tell you, circle it and say, kidneys cannot get rid of waste. So we will see, when we have metabolic acidosis, we will see a drop in pH, a drop in bicarb, and I'll see low or no CO2. And that's usually metabolic acidosis. So get used to those, look those, do some questions with that so you can recognize that for a basis question. Know your potassium, know your sodium, know your calcium, know your phosphate. BUN goes up with dehydration. That would be important to remember. Glomerular filtration rate, we want it greater than 60. Think you're driving on the road, foot on the pedal. The higher it is, the better it's moving. That's the filtration rate through your kidneys. Faster the better for the GFR. Creatinine clearance, make sure you understand that will be something that we will be looking for with that 24-hour urine. Check out in your Pearson skill book the 4.5 urine spec 24-hour review it if you don't know it. I'm going to tell you right now what it's about, so write this down. So when we're ordered to do a 24-hour urine, who can tell the patient about it? Who can instruct the patient about it? The RN. We're the only ones that can teach. So you go in and you tell them that your doctor has ordered a creatinine clearance 24-hour urine collection. So what's going to happen? Tomorrow morning, when you get up at 7 o'clock, you're going to pee regular in the toilet and flush it. From 7 o'clock on, after that void, everything is going to be collected in a container. It has to be put on ice in the bathroom or refrigerated if you're doing it at home. And every single urine will be collected in these containers. If you do one, it might take 2, until 7 a.m. tomorrow morning. At which time the labeled containers will be sent down to the lab to do the creatinine clearance. You have to document the INO, so every time you dump that urine into the container, make sure you're documenting the amount and making sure it's on ice. It might be a little different in each facility, but that's what we want to do for the test. Okay. which task associated with the 24-hour urine collection is most appropriate for the nurse to delegate to the UAP? Show of hands. Yes. Right, so ensuring that all of Ms. J's urine collection for the test is kept on ice. That is what your UAP can do. You have to instruct her, you have to teach her, and you alone can assess her. But your aide tells you it smells funky, something's up. Listen to them. Okay. The results of Ms. J's 24-hour collection reveals a creatinine clearance of 65 mLs a minute. How does the nurse best interpret this finding? Yes. Right, slower than normal, because normal is what? Excellent. Yes, very good. So the RN reviews Ms. J's laboratory results. Which laboratory finding is of most concern? Yeah, we're really worried about that potassium because what do we know about that? That can cause what? Right, she said it was for cardiac arrest, anything above 6. So signs and symptoms you should know for high potassium are muscle weakness, nausea, vomiting, and diarrhea. EKG changes such as tall, peaked T waves. You should be able to recognize them on a test. Do you know what that is? Now T should normally go a little bump. Instead, it's going up. Okay? So this is tall. That's the signature of the heart. You want to know and recognize what the basics are, and you should know that we're seeing the P, Q, R, S, T. Now the T usually goes like that, and then we start again with another P. And when we have hyperkalemia, that T wave goes crazy. And this sometimes can get wider also, QRS, but your T wave will come like almost up higher than the QRS complex. And it's tall, peaked T waves. And that's what you'll see on ward questions, and you may see that on ours as well. So what will we do for this person? And this is important for you to write down. So yeah, I want them on stat. I want them in a cardiac floor. So it's first line of treatment. We know the potassium's high. What is that word that we know, that medicine that gets rid of K? K-oxalate. Another one is chemo. You just need to know that that's what we're using in practice a lot. But for the test purposes and probably for boards, K-oxalate. Easy to remember, right? Because it's got K right in the name, and potassium has, we know it is K. So we get that. How can it be given? No? Oral or via a not a suppository, an enema. It's a good thing. So, ideally, they'll drink the container. They hate the taste of it. This is gross. It looks like chalky gray, nasty. It's a little tiny bottle. Shake it up. Offer them a chaser of ginger ale or push a paper drink. They'll get to go behind it with ice. Whatever you gotta do, explain to them. I know it's gross. I'm really sorry, but we gotta get that potassium down. It can hurt your heart. You don't want to have a cardiac event. And you kind of gotta scare them a little bit. And you feel bad about that. Finds it what? Potassium where? You're doing it already. In the colon, right? Grabs it, binds with it, pulls it out. So I'm gonna monitor for what? I want stools, similar to like when you guys gave what for our liver patients. When we give lots of those, too much to poop, and I'm gonna check and say, okay, withdrawals, how many times? That's important because that's what it's supposed to make you do. In the same vein, encapsulate, binds, pulls out, and they'll evacuate the potassium by a stool. So it's important that we document that they actually are stooling. Can I give them just like Exemplars? It doesn't have the same property that will bind with the potassium and pull it out. Okay, so if that was like a trick question, like if that was thrown in as a choice, don't bite. Okay? I will say to you, we don't like to give these enemas because they're unpleasant. But who do you think we have to give it to? Unconscious, obtunded, confused, those that are refusing to take it orally because they don't like the taste, nice, they just put it in. And it takes a little while, your left side lie them, try to get them to hold it for as long as they can so it will bind with the potassium and pull it out. Again, watch for the stool. So sometimes we do that initially when there's no symptoms. That's our first line. Go oral or go with the enema. But in an emergency, this is what I'm going to use. IV dextrose or D50 and regular insulin. Why, you ask? What's it going to do? It's going to push them into the cells, right? Because I'm giving that dextrose, I'm giving the insulin to deal with it. Another line of fire is IV calcium gluconate. And another one, IV sodium bicarb. Yes.
So if you're giving her calcium,
Gluconate.
isn't that for that magnesium or that?
It can impact that, but it's going to do what we want it to do for the potassium. We would absolutely be watching all the other labs. If we needed to replace neg, we would. And quite often we are replacing a lot of electrolytes. So all else fails with this, what can we do to get rid of this potassium that can give this person a heart attack? You could, if they weren't symptomatic, like early on when I'm doing the Caxley, I could go with some furosemide, diuretic, or Qmax, or mannitol even, that would help the extreme. But if I'm having somebody symptomatic, I'm not gonna mess around much. I'm not gonna give them a lot of time to turn this around because I don't wanna have a heart attack on my hand.
Would you dilate?
Listen to her. Yes, and everybody always, year after year, fans this on a select reply. Dialysis. So you have all these other options, and you have dialysis too. So, and it doesn't mean that they have to have an AV fistula. We may have to put in a tunnel catheter to do it now, but we will dialyze them if nothing else is working, because that potassium soaring is going to cause heart anomaly. Okay? So everybody's got an IV dextrose for D50 with regular insulin, shifts the potassium into the cells. I can give IV calcium gluconate, IV bicarb, and when all else fails, I can dialyze them. And that would be a good thing to know. Just saying. All right, so let's look at the prevention. So we talked about it a little bit already, so it's collaborative. We can't do it alone. We have to have our doctors involved in helping our patients maintain healthy lifestyles, treating hypertension and diabetes, an active lifestyle, identifying and managing hypertension and diabetes, which can't happen if people don't what? Well, they don't go to the doctors. So many people don't go to the doctors. They're walking around, they're taking time off, they have hypertension that's undiagnosed. They have diabetes or pre-diabetic and they don't know. People don't take the time to go to the doctors. We saw this a lot during COVID. People didn't get their routine checks. Now we have a lot of really sick patients coming in. So remember that the very meds that we give sometimes to help our patients can hurt their kidneys. Like ACE inhibitors can cause changes and hypertension. So make sure that you know that it can cause like a kidney injury, as can the regular stuff that we take after we've done too much crowd work, or we've lifted a heavy patient, or we turn to NSAIDs, right? Those can hurt the kidneys. So I think twice before I grab my Motrin that I used to always grab a lot. You know, because when you start learning about stuff like this, you're like, all right, is it that bad? Can I try one blanket and can I try one of those like bio sticks, you know, something that will help. Secondary prevention would be doing those health screenings, encouraging compliance, like you guys had said, and then going to the doctors to have labs monitored to see if they're working. So if I give somebody an ACE inhibitor in the office, I want to check that to see that it's not adversely affecting their kidney function, right? I won't know that if they don't come for labs. And we're all guilty, but we have to get better at that. Pharmacological treatments, we discussed. Some elders don't drink, I told you that, varying incontinence, and meds, diagnostics, very important, and dietary considerations, which we'll get into a little bit more. Know your interrelated concepts that we can't get rid of. Acid-base balance is going to come back to haunt you on this test. Health and wellness, perfusion, culture, cognition, as far as like, are they aware that they need to drink? Are they able to remember? The child, teaching and learning. So much of us, we're all learning about this right now. So we need to work with our interdisciplinary teams. We need to keep control of the glycemic. So we want to be checking those blood sugars and making sure that they're good. Patients need to be collaborative and compliant. Get a nutritionist on board, and we're going to talk more about why that's really important. Sometimes we can get biofeedback people on board to work with those that have problems with incontinence, or there's urogyne surgeries that can be done to help suspend as women age. If they've had multiple children, they may have cystoscopies to help. They can have problems with cystocele, meaning their bladder can come through their vaginal area and kind of like impede their urinary output. And with men, we can see pH. So there are other things that can happen that we can correct surgically. And then dialysis, obviously. Right. So this slide's very important. So know what acute kidney injury is and failure. That's your exemplar. It's the rapid decline in kidney function with azotemia. Fluid and electrolytes, imbalances, and acid-base balances. AKI is reversible usually. And that's important to remember. Can we reverse chronic? No. Yes. No. No, can't reverse it. We can treat it.
No,
And keep
I
them.
was thinking of how.
Yeah, you're thinking AKI. That's okay. I'd like involved. That's okay. You dare to be out there. Okay, so ischemia is one of the common causes. Make sure you know these. We see this with decreased blood pressure. We don't perfuse the kidneys. We see it with bleeding and cardiogenic shock. So if somebody's had an injury and they're bleeding excessively, they're not going to be perfusing to the kidneys. Think trauma, accident, stabbing, violence, and cardiogenic shock, which you've gone through, and you understand that when our body goes into that central survival mode, it's not gonna be right about confusing the kidneys as much as it is everything else. Heart and brain. And then nephrotoxins, NSAIDs, your aminoglycosides. So, what are your aminoglycosides? I'm hearing one word a lot, mycin.
I always think of my little mouse with big ears that look like kidneys, okay? Because inside here, there's little kidneys. And it's an awful mouse, but he's cute.
So think about mycins, because with a big ear. And the reason why I say this is because what do we know about the mycin drugs? What are they? No, what are they?
This is my little sad mouse.
Yep, what are their problems? What do they have?
Mycins,
We know it's all sick.
vancomycin, gentamicin, germicin.
Think of the little mouse with the big ears that look like kidneys because they are autotoxic, which means they affect the ears, and they're nephrotoxic, which means they affect the kidneys. Auto and nephrotoxic, and you'll see that in your boards. Think mycin, think the big ears on the mouse that look like kidneys. So, absolutely, your mycins. Anytime you're giving a mycin drug, you question it if the patient already had kidney injury, meaning their labs were in the tank for kidney, their BUN and creatinine. Is it worded sometimes appropriately? So do we give it? So if they don't already have kidney damage, yeah, we will. I give it a lot, especially vanco. But I always check the follow-up labs, and if they were skewed, I would be letting the doctor know. And I always go in the room and I'm like, hi, I'm Christine, I'm your nurse. What did you need? What's your date of birth? And I'm talking to them at a normal level, and I want to see if they're not going, I'm sorry. I want to assess the hearing before I give the med. Because the next time I go give it, if I walk in the room and she seems to be having problems listening and hearing, then I'm concerned that I've had that other effect, the autotoxin. I just don't want you to forget about that it can affect the ears as well. If you think about it, especially with children, they can't tell us as much. Sometimes people get like tinnitus, like a ringing in the ears, or they'll have an audible loss. But just think of the most big ears that look like kidneys, it's auto and nephrotoxic. All right, so NSAIDs, aminoglycosides, which are your mycins, gentamicin, vancomycin, ACE inhibitors, dyes, and heavy metals. Those are all nephrotoxic. And as far as injury, we're talking about infection, major surgery, and tumors. So we have your clinical manifestations. You'll have a low GFR. Remember, we want that greater than 60. The faster the better. I have a rental car. It's a BMW. Now mind you, I drive a Honda CRV. I'm having fun with this. It goes a little faster than I'm used to. But I thought of that today when I was driving here. I'm like, I am definitely, my GFR is a little out of control here. So remind yourself, GFR, we want it greater than 60. We want it to go faster. We don't want to do either, but we do want a GFR to be. So we have an increased BUN and creatinine with this manifestation. Azotemia, what is that? I can't hear.
Abnormal nitrogen levels in the blood are really high.
Right, and what makes us get azotemia? You know, I'm throwing that out there.
That's usually protein, isn't it? That's okay.
Well, yeah, but it's usually a breakdown toxic release of protein. Like, that's why we give like lower protein to kidney patients, just so you know. Fluid retention, so they're getting edematous. We'll have those electrolyte imbalances. Neuromuscular, wonder where I'd have that with kidney. Somebody said, the young lady in the back, maybe Barnes girl, You said you were worried about magnesium. How about calcium? What does calcium look like when it's low? Trousseau's, tropsis. And so which is which? Trousseau's, I call it teapot. Teapot. Trousseau's. And then the other one is the tetany at the base, right? You can with that muscular spasm on the cheek. Is that a diagnosis? No, but that's a call to Doc K. He's got a positive Chekhov's, and he's also got a positive Trousseau's. Do you want to get a calcium on this patient? So you're right, think about all the different things that are going on. Maybe you have to go back to the slide. What other things might a patient feel with low potassium? Anybody been pregnant and woke up in the middle of the night with huge calf pains? Right? Jumped you right out of bed. I can remember it. My baby's 27. Right? That's usually potassium, low potassium. You wake up out of bed like that, have some orange juice that day. So there'll be muscle weakness, nausea, vomiting, diarrhea sometimes, weakness in general. So we'll have some physical manifestations of it, and then we'll have the metabolic acidosis, which you're going to get more comfortable looking at. Anemia, because we know what's produced in the kidneys. Yep, and anemia, because of this issue and the stuff with the bones, and we'll get into that. Confusion. We can have seizures, especially if what's off? Sodium and calcium. We can have seizures, so I want seizure pads on patients with hypokalemia. And there can be anorexia, they just don't want to eat, and nausea, vomiting. So initiation phases, know these. They can last hours to days. Oliguria is an increase of potassium in this time frame, magnesium, urea, creatinine, BUN, and uric acid. And these patients are making a minimum 400 urine in 24 hours. They're really making a little bit. And we get hyperkalemia occurring, possible heart failure, fluid volume excess. Remember, 1 kilogram of weight equals 1 liter of fluid. And then the next phase, in diuresis. So in this oliguric phase, there's decreased urine. In the diuresis, the kidneys are now excreting the waste, but it's not good at concentrating it yet. So it can cause hyponatremia, hypokalemia, and dehydration. So kind of almost like a diabetes insipidus. You'll see tons of fluid. It won't be very dilute. It will be very dilute. It won't be able to concentrate, so it'll be more like watery. And then in the recovery phase, kidney functions at a normal level, and it can take up to 12 months to get here for recovery, to get there. So you need to take, throughout this period, frequent labs, MD visits, and dietary restrictions to stay in a right lane. And this is the only way we can address acute kidney injury and protect it from going more. Hyponatremia, hypokalemia, and dehydration. You're welcome. So in this time frame, fluid restriction is usually less than 2 liters a day, or about 1.5 liters a day. Now mind you, this is acute kidney injury. We want them to feel different. ACE inhibitors we worry about because it can, while it preserves the heart, It can hurt the kidneys, so we have to make sure they're not doing that. Monitor those calcium changes, the neuromuscular changes, with potassium, with the cardiac abnormalities. Again, I want you to tell me, what can we do to bring down the potassium? Here are 4 things. So D50 with regular insulin, IV calcium gluconate, IV bicarb, sodium bicarb, and dialysis. You have a class that knows that. You'll be so happy, be proud. You'll be happy too. So, K-oxalate, IV glucose, or D50 in parentheses, with regular insulin, IV calcium gluconate, IV sodium bicarb, and if that fails, dialysis. So those are all the things you would pick. All right, moving on. Yes.
Dialysis is at the last intervention of your exposure?
Yeah, because that's invasive,
Yeah.
and this is for an acute kidney injury.
Okay.
So we don't have an access point, so we have to do a tunnel cab, but we absolutely would, because we want that K down.
Okay.
We're not getting fast results, we're gonna bury a tunnel and get it going.
And then with the phases, you said the initiation lasted from hours to days, and the recovery for 12 months. But what about, like, is there a time frame for the 2 middle phases?
Just so that you know that it can take a period of time, but it can take up to 12 months to get to recovery.
Correct, but like with the middle 2, like, is that?
There's not a specific time frame. It's gonna be different with each patient.
Okay.
But the whole thing is really, I just wanted you to realize that it can take a long time. So next you guys need to understand this as well. Pre-renal, interrenal, and post-renal. So there's 3 different reasons why the kidneys are unable to function. So when I think about pre-renal, I want you to think about damage above the kidneys. So shock or heart failure, low blood flow because of shock, hypoperfusion, fluid volume deficit, ACE inhibitors, and NSAIDs. So before the kidneys, these are the things that can cause issues. You got that? Intrarenal, those are directly damaging to the kidneys, to the tissue itself. So group B strep infections, manifested by acute glomerulonephritis, any of your gentamicins or mycin drugs in general, if they should get a kidney sepsis or urosepsis, it's going to injure the kidneys or scar them. Vancomycin is a big one of those bad boys too. We also can hurt them with contrast media, the dye, especially if their glomerular filtration is not good. And diabetes. So we want to make sure if a patient has radio contrast dye, that we message the doctor, do you want to get some IV fluids run to just help get that dye out of the body? Or really increase the oral intake of the patient if it's safe to do so. You can have your aide offer frequent water or drinks. We want to clear that from their system. We want them peeing it out. Let's go to post-renal. That's your obstructions. That's after the kidneys. Think below the kidneys. So that's the little guy who can't pee, but he's not telling anybody, or his stream's really slow, or he's retaining because he's got BPH. Now, does he have benign prostate, or does he actually have prostate cancer? Could be either or. He could have, or she could have kidney stones. That's blocking the exit. We could have bladder cancer. We have fecal impactions that prohibit us from peeing because we've had such a large stool that is blocking, the exit out. Does everybody have a good handle on the categories of what can cause it? Okay, good. So let's talk about, treatments. So we want to eliminate the cause, remove the necrotic agent, so take away the ACEs, try a different drug other than amycin, remove the obstruction, so get that TURP done. We want to identify that the stones have, either left the body or we're going to facilitate that. Maintain fluid balance, increase cardiac output, have a normal blood pressure, not hypertension. Possible renal replacement, we may need to dialyze them temporarily during the acute phase. And treat the electrolyte imbalances specifically. The signs and symptoms of hyperkalemia can lead to cardiac issues. Maintain acid-base balance. So increase cardiac output and avoid the nephrotoxic drugs. Nutritional support, individualized to the patient's needs, to teach them about what foods to avoid. And if you have to get dietary involved, do so. We want low sodium diets. We want typically 2-gram sodium diets per day. We don't want them to be picking from a high K list. And we want them to have lower protein. Do they need some protein? Yes. But they are not people to go on a keto diet. Okay? And the goal is to restore normal chemical balance and prevent complications until renal function is improved. Some meds that we may use, and this is the part to write down, we might use IV dopamine to increase blood flow to the kidneys in a low dose. It will increase kidney function when they're in trouble. And then to speak to my students who correctly said, could we try a diuretic? Yeah, we could. We could try a loop diuretic on these people. Furosemide or Lasix, you know what it is, or Bumax, which is another one we use. Which one would I avoid? Furosemide. You would avoid spirulactone, right, or aldactone, because it's potassium sparing, and you don't want to spare the potassium. Let it go, right? We can use mannitol. Which one do we usually use mannitol? When have I talked to you about mannitol before? ICP, right? So it's kind of weird that I'm saying we couldn't use it here, but we can. It's used rarely, but it increases the secretions of electrolytes and waste. So in a pinch, we'll give it a try. But who won't we give mannitol to? No, we might do that, so. Fine. Heart failure. So we should never give mannitol to a patient with heart failure because it increases vascular volume. So we will give, like I said to you, and I'll say it again, D5 dextrose with IV insulin. We will give another med called aluminum hydroxide, which binds with phosphorus to treat within the GI tract. And we will give calcium carbonate with meals. Why? Why are we giving Tums with meals? What did you say? Did you say anything? What did you say? But why? What does it do? It does. It binds with the phosphorus and it prevents the calcium from the bone from being leached out. But I will tell you, you have to know this because who has Tums in their house? Okay? So if you're going to give Tums to a patient and you're giving it to them before their meal, as your order says so, make sure you explain to them. I have had patients say, oh no honey, I'll keep it, but I don't have any heartburn. And I said, no, sir, this is not given for heartburn, this is given because you're a dialysis patient, and we need to, protect your bones, and this will help with getting the phosphorus out. And he goes, what are you talking about? I think this is for heartburn. He goes, I have been taking them all week, and he opens the drawer and he has a rainbow of colors of Tums. The two things have happened here. The nurse did not educate the patient properly. And she also created what could be, she could be terminated because, well, yeah, it's Tums. Yeah, I received it on this, and she has to go home, and I can go right at CVS on the way home. In that role, you gave a medication that was not given and taken in front of you. So if you refused it after being properly educated, then you needed to take it back and lease it and put it back in places. So instead, he has a rainbow collection of Tums in his drawer, and that's an incident report. Okay? So, and that's one of those things in practice you guys will have to get good at, explaining to elders, because sometimes they're like, you're a mean one. And I'm like, I'm not a mean one. What do you mean? Well, the nice ones, they just leave the meds there, and then they let me take it as I want to. I'm like, no, I'm one that wants to keep my license. And I have to. I'm really sorry, but I have to stay here while you take all your meds. You're really going to make me take all of them? Unfortunately, I have to. All right, and then it'll be like angry. I usually take 2 in the morning at 8, and then 2 more at 10, 2 more at 11, and they make it a day project because how do the pills know where to go? So we have to educate them. And you know what? They may go back home and line their kitchen table to be their job all day long to spread their meds out. But we, as nurses in practice, you never leave a med. If the patient said, I'll take it right after I go to the bathroom, I'll take it back then and I'll come back with it when you're done. You've all seen it. You've seen meds left on a tray. That's an insert report. You can lose your job and your license. So I just wanted you to know in practice, don't do it. But this is a good example of different meds have different uses, different education points. And yeah, I could give the same Tums for epigastric burning or heartburn. But in this case, it's prescribed to help them with the excess phosphorus to bind with it. Because we know calcium and phosphorus are directly opposing each other. And when one is high, the other is low. So that's what that is for. All right, so we got there. You want to treat the cause. Get this. That's good. All right, so these are your example of nursing care things. Make sure you're doing all these things. You want to check those labs and check them again. Don't assume your doctor saw the potassium of 6.5, give him a call, or message him and say, hey, Mr. Jones has a K of 6.5, what are we doing? That's a critical level, and that should be called in right away. You want to prevent those infections, both in their skin as well as in other areas of their body, and provide skin care and psychosocial support. We'll get into that more later. So, which intervention would you delegate to the first-year student nurse whom you are supervising for Mrs. J's potassium level of 6? Raise a hand. Nope, it's going to be 1. And it's going to be administer the sodium cholesterol sulfate, which is another word for cancer that you need to remember. So you will administer that orally. So the reason why the others are wrong is, would we give spironolactone? Because it's why. Would we assess the ECG for 12-10 T waves? We would, but would we expect a brand new nurse to? No, but I'm expecting you to see it for your boards. I would show it to her though, whenever I'm precepting, I'm like, look at this. How about administering potassium, 10 milliequivalents orally? No. Because why? We're trying to lower it. Okay. Good. An experienced LPN or LVN reports to you that a client's blood pressure and heart rate have decreased. And when his base is assessed, one side twitches. What action would you take at this time? Right, because we know that it is not a diagnosis, right? So a positive Charcot sign, facial twitch on one side of the mouth and nose and cheek in response to tapping on the face, just below and in front of the ear, is a neurological manifestation of hypocalcemia. The LPN is experienced and possesses the skills to accurately measure vital signs. So they cannot do, you have to request the consult. I would immediately go and say, ooh, that's concerning, let's close the labs. And if the labs were not reflective of a low calcium, I would message the doctor to see if he wanted to get them rechecked. And reassess the blood pressure. That can be done by your LPN. Pupillary reaction, that would be you.
What's the answer to that one?
Any questions? So Ms. J is receiving IV piggyback dose of gentamicin, garamicin, every 12 hours, which would be her priority for monitoring during the period that she's receiving this drug. So yes, because we know that gentamicin can be highly toxic. You would monitor creatinine and blood UN for elevations, which would indicate that for toxicity, and all of the measures are important, but not specific to gentamicin. Okay. So the next exemplar is chronic kidney disease. Does anybody need a break?
No.
Okay. It's a chronic kidney disease, it's kidney damage or decrease in glomerular filtration rate, that GFR, over a period of 3 months or more. If untreated, it can lead to end-stage renal disease. Common causes of diabetes, hypertension, nephrosclerosis, which is like a hardening of the kidney itself with dead areas, and primary glomerular disease, or glomerulonephritis. Think of your Charcot. The way it would manifest is an elevated B1 creatinine, uremia, which is what? What is it? So yeah, but it's manifested how? They can slip into a coma. It almost looks like your liver patient that has encephalopathy. Did anybody ever seen anybody with encephalopathy? They can literally sink into a coma. And that's what they look like. And they typically, if this is an end-stage chronic kidney disease patient, we'll see this the night before they're being dialyzed sometimes if they're really sick. We will sometimes see oliguria or anuria, so very low amounts or no urine, anemia, metabolic acidosis, increased respiration rate, and death. What does that sound like to you? What kind of breathing? That's exactly what it is, Kussmaul. And abnormal, so if you were given a test question, Kussmaul, then that would be what that was referring to. Abnormal phosphorus and calcium levels, fluid retention, we would see those electrolyte imbalances, hypertension, fatigue, weakness, uremic pressure, and that's when they're talking to you, their breath smells like cake. It has like a metal taste in their mouth, they'll report a metal taste in their mouth. And then, has anybody seen uremic frost? So when the school that I taught before, I used to work in a lab for this particular topic, and I used to put like flannel all over my face. Because literally around your mouth and on your forehead, it's almost like the urine is coming through in a powder, in a crystal form on their skin. It's very itchy, causes pruritus. But they call it a uremic frost. And it can give like a green-yellow cast to the skin as well. Stage 5, there's 5 stages. 1 is the least severe and 5 is ending. So continuing along with our case study, this is a select all of time that you guys had to be super good with. So which risk factor is Miss J's history indicate increased risk for chronic kidney disease? Select all that apply. Is it number 1? No. How about number 2?
Yes.
Yep. How about 3?
Yes.
No. How about 4?
Yes.
Yes. How about 5?
Yes.
Yes. And what about 6?
Yes.
You nailed it. So this is that frost I was telling you about, like I was trying to find a good picture. So you can see on my African American woman, she has more of that kind of like a yellow green tint, but on this white gentleman, you can see like a powder, or like it almost looks like flour, I'm not kidding. I see it the most around the mall, but you see a little bit around the mall. Remember that if calcium is up, phosphorus is down, and vice versa. There are inverse relationships in this illness. You just want to wash it off. I mean, you just want to keep them clean because it smells like urine. Their whole body will smell like urine. It's like seeping around because your kidney can't go there.
So it's almost like salt, right?
It is. It's like a uric acid crystal, and it's urine crystals. It's really sad. And they can't help it. So when somebody's like, oh, they smell like pee, like, don't stand in front of them, like, just take care of them. Like, I've seen that, and that makes me very angry, because they can't help it. So let's go through the stages, they're important to know. And yeah, they will smell like pee, so let's make sure that you're getting your nursing assistant in there, and offer to help. Be like, hey, do you mind if we go watch Mr. Jones, because I want to check out his skin, do it together, show her how you want it done, show him how you want it done, and have that communication. You're checking them out, you're seeing if they've been scratching and digging and bleeding, and you're showing your aid that you're not lazy and that you're willing to work with them, and you both are on the same team. Don't miss those opportunities. You know that they are fast. Okay? You'll get a lot more cooperation from your aides if you help them. And they'll know you're the real deal. Okay, so stage 1 is normal, okay? But they're in a chronic kidney disease at this point. But look at, they're asymptomatic within the description of clinical manifestations. So they have a normal BUN if I even checked it, and the creatinine is normal. They will probably have some kidney damage, but within a normal, slightly elevated GFR, which is okay. So the GFR is above 90. So it's really hard to know that this is an issue. This is probably all of us during COVID. Because I don't know about you guys. We sat here for hours on end not drinking water, right? Our kidneys were screaming. Stage 2, look at that GFR, it's coming down. Remember, I don't want it less than 60, I want it above it. 60 to 89. I'm starting to see some mild decrease in the GFR. They're still asymptomatic, but they might have hypertension that's undiagnosed or untreated or not treated well. Maybe they're not compliant. And then stage 3, look at that GFR, guys. That took a plummet. So that's dangerous. That's less than 60. I'm not happy. Moderate decrease in GFR. Now they have hypertension. If I check their labs, they have anemia. Reporting to me that they're fatigued all the time. Then they have a decreased appetite. The BUN is slightly elevated, and their creatinine is elevated. We're heading into really bad territory. The stage 4. All right. Oh, so sorry. Thank you for telling me. Stage 4, 15 to 29. Don't even send them down to get a CAT scan without clearing it with a doctor, because you'll get a call from radiology and they'll say, are you kidding me? This guy's GFR is 15. You want to clog his system completely? Oh, I don't know. I just was told by the doctor that they wanted a CAT scan. Well, call the doctor. Okay. So you're going to call the doctor. So, doc, I just sent down Mrs. Jones, and radiology just said I was crazy for sending them because the GFR is so low. Yeah, they get like that. So, all right, you know what we'll do? We will hold off on that, or the doctor will say, we'll do it, but we'll do dialysis right after to clear it out of the system. And sometimes it's not even good enough for the radiologist, sometimes the radiologist said, I'll call the doctor directly. Because what's happening at this point is on a doctor-doctor level, he's saying, you're taking a risk with whatever function this patient's kidneys have left. And I'm not taking it, you're taking it, and I'm gonna document that. So now it's in a doctor level. But I'm not kidding you, this happens. So this patient is already severely decreased GFR, and there are reasons why the doctor wants a CAT scan, like, is there a blockage, is there something going on, but maybe the radiologist is saying, hey, do an ultrasound, do other stuff first, like, think about this, you can maybe ignore it. They're like heading into end stage. Hypertension typically, anemia, malnutrition, and we'll talk about that. Those are the people that are taking on the 2 liters of Diet Coke, and they got metabolic acidosis, they got hypercalcemia, uremia, azotemia, they're breaking down protein, making all those toxins, yes.
Could you do a plain CT and still see what you need to see and not just a CT?
They don't see what they want to see, and that's the problem. But yeah, that would be a thing that the doctor could say, all right, just do it without contrast, but the whole page gets to see the blockages and stuff. That's a very good point. In some cases, like with brain stuff, they can see stuff without it, not to the degree. But with this, they're looking for like specific blockages and stuff. But we're definitely gonna have SPAC IP when the creatinines with stage 4s. And guess what, stage 4, that doctor, they better be talking to them, and they don't do very good at this. And I shouldn't stereotype because some are better than others, but I find that doctors do not prepare patients for your kidneys are dying. You're gonna have to go on dialysis. Because already your stage 4 should be being talked to about, so, would you like to do hemodialysis or peritoneal dialysis? What? I know, I was the other day, they told my father, and he was just like blown over. He's like, dialysis? That's the thing that people do at a machine. I gotta do that? Well, yeah, Dad, your GFR is 13 now. That's what they finally can't hold them that. But then, the way they said it, it was like, it's gonna fix you. No, get it done. Just do it. That's not the kind of way that you should decide about dialysis. It is a life-changing event. Nobody in here has any loved one on dialysis that they want to share.
I have Brian sent me a picture of her fistula that she just got.
She just got it.
Yeah.
So is it a regular acute fistula that was planted?
It's like what you said, she flies across the summer, she like flies across and does stuff with some kidney damage.
That's awesome.
She was hit by a truck when she was 16.
How old is she?
She's like 54 now. She's like
And so why did she end up having to get dialysis instilled now? Why is she going to have to have it?
but I think, well, she.
The trauma?
Yeah. She was hit by a truck.
Wow. Yeah.
That hypercalcemia way off. I thought it was low. I realized I got phosphate was high.
Everything's also good at this point.
Okay.
I know. It is. Yep. She just had that pendant. I wish you guys could see it. So it's like an angry red area on her arm that's been planted. This is a good time to check out our AV visual sheet for a second. Because this is the conversation I know these doctors will be having with patients at this point. So if you were to tell a patient in your own words, what is an AV fistula? I need somebody who can explain it with it, raise their hands. Yes.
It's a procedure, where they on the arm, they find the artery in the vein as an access point for
That's a good way to put it. You want to try a different way, or?
I was going to add to that, I was going to say, you could say it's used to increase blood flow and to the arteries and
Anybody else have different words they used? So I would just say, it's kind of like a surgical marriage of an artery and a vein that's brought together and brought to the surface of your arm or wherever they deem necessary or viable. And they usually start in the forearms. And I say this because people can have multiple attempts at getting AV fistulas throughout their life, and there's only so many spots to go to, people. Why would somebody have to have a fistula? What kind of dialysis? Hemo. So remember that, it's for hemodialysis. So if there was a test question that talked about a vascular access for peritoneal, that would be correct, right? So what do we as nurses assess for patients that have a AV fistula? Say it out loud, you. So you want to have what about a brewery? Do you want one? Yes, this is the one time a positive brewery is a good thing. Does anybody know what a brewery sounds like? It does, it sounds like a swooshing, like almost like a heartbeat. You put your stethoscope, make sure your stethoscope's clean over it, and that's what you want to do every shift is assess it for a positive brewery. And then you want to say what else? Positive thrill. So that means that when you place your hand over it, you feel this vibratory effect. It's like, you can feel this vibration. You feel it. That's a positive brewery, positive thrill. I'm giving you a report, and you all go, you're getting a report. I'm giving a patient, Sandra, she's dialyzed Tuesday, Thursday, Saturday. She has a fistula in her right forearm, there's a positive brewery thrill. I ordered an early RX for her, she's going today. And she's had issues with sight this far. So every time that you hand off a dialysis patient, you want to let them know what their days are for dialysis, where their vascular access for the AV fistula is, and if it is functioning properly. I can easily say to her, I can hear her breathe, but I don't feel it through. And the patient reports pins and needles to the fingers, and the doctor can notify. But I never just check it off because it's an epic. I actually do the assessment. And any other questions on that before I move forward? Don't take a report from a nurse that won't tell you that stuff. If you're going to be sitting there like, wait, she's going to say it, he's going to say it. You have a dialysis patient because you got in there 2 minutes early and looked at your patients, and you know your patient's going for dialysis today, and you're expecting that nurse to tell you the same things I just said. They don't. They didn't look at the patient, which makes me afraid because did they get a blood pressure on the wrong arm? Did they look at lab going? Is there a limb restriction on that arm? Yes.
I have a quick question. I work as a phlebotomist, and I've had cases where patients have fistulas on both sides. They told us to go below the level fistula. Is that right? I want to ask.
So typically, if they have a second fistula instilled, it's because one isn't working. So they should identify for you what side is the viable side. Because that is the other thing that we're going to talk about is that, do they not allow you to direct the foot?
No, you're not allowed to show.
A nurse could do that. But that's a good question. So what should the nurse assess? We know that one. What is important to keep an AV fistula safe or protected in any way? Absolutely. In what ways? There's 3 ways we can protect it. How? We put a sign above the bed that says what? No BP, no venous rods. What? No IV. And we put a band on that arm that says restricted limb. And we educate the patient. If they're alert and oriented, we tell them, don't let anybody do anything to this arm. And the ones that have recently been told that they're really good about it because they're scared. And that's great. I always say to them, that's good for you. You protect that arm. But in her case that she was mentioning, and I mentioned to you, that patients will often have multiple AV fistulas throughout their lifetime because they fail. And if we can angioplasty them or vortex bypass them, which we can in most cases, or clot bust them, then they have to get another access point. Her question as to love was, what do I do when it's on both sides? And my answer to her was, find out which one is being used, because obviously one has failed, or one is failing. You never want to go after the new side. So, AV fistulas, if I plant it today, can I use it tomorrow? No. Why? Has to mature. How long does it take typically? At least 3 to 6 weeks, but I've seen up to 6 months necessary. to do that. So what do I do if I have a patient that slips into stage 5, and I need to dialyze them? What do I do? I would do a tunnel catheter in their neck. And this is a surgical installation goes right into their vena cava, and it hangs down like that. All right. We'll get to that a little bit more. So I just wanted you to know that stage 5, that's endgame, guys. That's end-stage renal failure. They have overuremia. These guys are on dialysis or they're on a transplant list. And lucky are they that can get one. So treatment to prevent it, underlying causes would be treated to prevent complications. Remember those phosphate binding agents, the Tums calcium supplements that we also give, the antihypertensive and cardiac meds that are working, but we want to avoid the ones that are causing problems. And we might have to give them erythropoietin because they're not producing red blood cells. And we might have to do renal replacement therapy, such as dialysis or a kidney transplant. Complications of end-stage renal disease. Anemia, because of the decreased production. So they can also have bleeding from the fistula site when they're accessing it and de-accessing it. And periodically, I want you to check it when they come back from, always when they come back from dialysis, just eyeball it, make sure it's not bleeding. Usually they have made sure it's not bleeding, and they just have an adhesive bandage. You would put gauze around the arm and cause like a tourniquet effect. You would just leave the bandage on that they come back with. Typically, they just leave it there for the day, and the following day it can be open to air on their off day. So bone disease, because of the phosphate levels, can cause decreased calcium levels. They have abnormal vitamin D metabolism. And then hyperkalemia. And because of that, we need to give them a little more carbohydrates because they have that catabolism going on. Hypertension, we want to watch the sodium and the water retention because they have that problem with the renin angiotensin. I just want you to be aware of that. And then they can, because they have so much fluid in the body, they can actually get tamponade and pericarditis. They can go into multi-organ failure. I've seen this, unfortunately, firsthand with my dad. They can go into heart, lung, liver failure because it just all shuts down. They just have too much fluid in their body, can't do it. Nursing K, you want to monitor the fluid electrolytes, respiratory status, encourage optimal nutrition. So we restrict protein to a level. We will sometimes give it, and sure, we will include protein within meals, but not excessive. We would keep their sodium restricted, usually it's 2 grams. Fluid intake will vary, and this is important to remember. So it's usually 5 to 6 or 800 mLs more than the previous day's 24-hour output. Now remember, end-stage renal, how much output am I getting? Not much, it may be in Europe or very little bit. So this is what they get the whole day. 500. Anybody thirsty? Anxious? So my father he didn't have the strength in his hands to open these. So I say, Chrissy, you open this for me, just leave it in the fridge, and I'm good. Little did I know, my sister Anna stopped by to do the same thing, and my sister Jamie stopped by to do the same thing. So all of his daughters were thinking we're being good daughters, and he ended up putting himself in an overload a lot. And they would say to us, why is there excessive weight gain? Because our dialysis patients are going into dialysis. They wheel them right onto a scale, and they weigh on the way out. And the thing that you get from a report from the dialysis nurse is, okay, I'm sending you back with Mr. Lenny Piebla, and he just, we got a little aggressive with him today. They took off 10 liters. That's a lot. That's 10 kilograms. And that would be the routine for him, that they would really, really draw the hell out of that because the fluid was moving into his lungs and his heart and his causing a pump, so they would really get aggressive. But I will tell you, what do you think happens to these patients on dialysis day? They get hypotensive, and what do we do for patients with hypotension? We love to give fluids, right? Not what we want to do with a patient that just had fluids taken off. So you have to be really careful with these patients, and I will tell you, remember this, dialysis days, fall days. They may not be fallers, but on dialysis day, they have to seek equilibrium. They're all skewed up. They've been 4 hours having things pulled off of them. I had more falls from patients on dialysis days than I care to tell you about. And so even if they're normally an independent walkie-talkie, on those days, they're battled against their will. If they are mad at me, I'm sorry. Because you know what, Bertha? I'd rather walk you to the bathroom safely and soundly than find you on the floor because you got a little weak and dizzy. And I will make sure that I tell my nursing assistants too, because they might not understand how complex dialysis is to the body and about this equilibrium syndrome that you do. Vitamin supplements are important that they get nephro caps. They can't just take Flintstone vitamins from CVS. They got to have specific ones that are targeted towards the deficits that they have in their diets. We'll monitor that potassium intake, and like we said, skincare. We want to promote self-care as long as possible, and alternating rest periods with activity. My dad would be so tired, he barely would want to eat. I would wrap a sandwich for him to just eat, and then he would go to bed. So that those 3 days of the week, guys, that they're dialyzed, they lose it. Because they're dialyzed and they're so damn tired, they just want to go to bed. And like I would get calls from dialyzer that he didn't even wake up, which is awful. Promote emotional support, like get them to talk because it is depressing. And a lot of times the doctors have done a great job preparing them, like, this is your life now. Well, doctors are good about dialysis will help with this. This is the next step. But they don't let them know that this is your life now. It's 3 days a week, committed to a machine until you die or you get a kidney. And it's a big commitment. And I would ask you all to look at a dialysis center before you let a loved one agree to it if it's not the right thing for them. If they're young, like our aunt, in her 50s, they have a chance of getting an organ, then by all means. Or if it's us and we have some sort of toxic exposure, absolutely dialyze me through a printed catheter or a temporary tunnel cath. But I would think long and hard about entering in my later ages of life to a dialysis commitment. I'll have to decide when I get there, but I just want to make sure that education is a part of that because I don't think people fully understand what it's like. So Ms. J's plan includes the nursing concerns, excess fluid volume, what interventions are appropriate for this nurse. Let's think about that. We got to measure daily weight? Absolutely. Are we going to monitor daily intake and output?
Yes.
What about restricting sodium intake with meals? Please do. What about restricting food to 1,500 ml plus urine output? No, that's a trick question because we know that it's 500 to 800 sometimes plus what they did the day before. What about 5? Assess for crackles in the lungs every shift? Absolutely. I just told you my dad went into respiratory and heart and liver failure, multi-organ failure. Check for peripheral edema and no any increases. Yeah, because they can get anaphylactic, that fluid that the kidney normally gets rid of. It's just cooling and it can go everywhere. So these are those access points. So the vascular access that I talked to you about in the neck, that's the temporary one that we do if we get into an issue and we've been exposed to a toxin, or we can't dialyze somebody who's potassium sky high. We would put in this catheter. We used to call it Minton catheter years ago, but it's basically a tunnel catheter, and it's put in the neck. And it usually has 2 ports one for exchange, one for return. And but in the meantime, if it was somebody that, like my dad needed to have it planted, they would plant that vascular access like your aunt just had, marrying a vein and an artery together in the arm. And we'd watch that closely to see if it began to work, and the nephrologist would be the one to determine, yep, we're at a place where it's going to be okay to use. And this right here is a graft, and this can be sometimes done, or it can be done as a bypass to repair an AV fistula. You might say that they would say somebody's in for a graft repair to repair AV fistula. And those can usually be used right away because it's a man-made material. So you would have to get orders for that. And then understanding what hemodialysis is, I hooked up these machines for 4 hours, 3 times a week. It's either Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. They can get hypotension, they can have muscle cramping because it pulls off the K. They can have exsanguination, which is bleeding from the site of the AV fistula. They can get dysrhythmias, and they can have an air embolism because of occasionally we will see this. The dialysis disequilibrium is what I talked to you about. We typically see it with people with very high BUNs. And a clinical manifestation you should know is a headache, nausea, vomiting, very restless, decreased level of consciousness. And we would see this usually in the dialysis center, and they'll often get Dilantin because they know a seizure is coming. And they usually see it before it happens, and it will typically happen at the dialysis site. But if you get a patient back from dialysis, they are at risk for this. So be prepared to initiate seizure precautions and get Dilantin from the doctor. You want to report it right away. This is what I think is happening. This is what's going on with him or her, and get ready to use Dilantin. Now, some people may choose to do peritoneal dialysis, and this is usually the person that has a wife that is a nurse, and they will say to them, "You can do this at home, ma'am, right?" And you're like, "Oh, okay." I was really careful to decide. I didn't want to get involved now with my dad because I knew that would be a nightmare, and he wasn't a candidate. You have to be somebody who doesn't have it as bad a stage that he had. He was getting very uremic. But it is an option for some people, and think about it, for your aunt, for instance, she's young. People that are working still, they can sometimes do this at home while they're sleeping. Or if they're autonomous and they have the dexterity to do it themselves, they have to be aseptic about the technique with it because they're at high risk for what? They can get peritonitis if there's swelling, or see this drainage bag? If this drainage bag, after the diastole runs in, all day long, or say you run it in and you clamp it off, and then you can disconnect. But when you hook it up to drain it out, it should be like urine, like clear yellow urine. If it's cloudy or murky or foul smelling, that's a red flag for peritonitis, as is swelling at the site. So it does remove toxic substances in this diastolate. It's a slower method. It's used through osmosis and diffusion through the abdomen in your peritoneal membrane. There are complications. It's mostly we associate peritonitis, but it can be bleeding, and then for some reason it throws off the triglycerides and it can be higher. For some reason I was reading about that because I was aware. And I just threw this picture in there for you because there's another mechanism that I just want you to be aware of, that if we have somebody who is really, really sick with a high potassium and we need to dialyze them, this is what we'll do. We'll throw them on a CRRT, continuous renal replacement, as critically care ran dialysis machine that's run usually 24/7 for a period of time, usually a couple days up to a week, depending on what's going on with this person that they think they can clear the kidneys if they can do it. They'll usually use it with clients that have AKI, so not somebody that needs to have a fistula, but they got that indwelling line, and this is what's going on. And so CVVH, the continuous venous hemofiltration, as well as the renal replacement would be done in the ICU, and we'd be trained to do so. Now that dialysis, that peritoneal dialysis I talked to you about, some people do like the idea of it because they can be in their own comfort of their home, they're not going to that sterile environment, being hooked up like a board to a machine, they are home, they're filling it, they're drawing it. Who thinks it like that versus going to a place, and just doing it in the house, you know, reading a book or, you know, like that, right? So, I mean, it does have its benefits, and some people it works well with if they have assistants or they have the ability to do it themselves. They perform exchanges depending on what the doctor prescribes, it can be multiple times a day, over 24 hours, 7 days a week. They do it every day because it's not as good as the dialysis, but it's done more routinely like our regular kidneys would. They get peritonitis. But all the stuff is in there. You have boxes and boxes and boxes of diastolate that you have to pack in the hallway. You have a machine that will help dialyze you, IV poles, and that's okay, if that's okay with you. But I think they need to let patients know that your home becomes your medical facility. You can't escape it, it's with you, yes. Insurance mostly covers these choices, and actually hemodialysis is more expensive than peritoneal dialysis, so they would love everybody to do peritoneal. And this is a real type of nursing to get involved in. If you're a visiting nurse, you'd be seeing a lot of these patients, or if you want to be a dialysis nurse, it's definitely a high need field. But it's a choice, and I think that they need to be more honest with patients that you either go to a place or it comes to you. So, you have a question?
I was saying my grandmother had that, but like after she had so many boxes left over, and I was open, and I couldn't take them back.
Isn't it crazy? It's just wasted. The amount of supplies they just deliver is overwhelming for us sometimes.
They're like, just got them and dumped them in the tablet for
And it's sad. So she did peritoneal at home. How'd she do with that?
She did it for like 10 years almost.
10 years. So what ended up, is she with us still? What ended up taking her?
I just think that works. I was young when it happened, so
Yeah.
like, I really didn't understand.
Do you remember it like, a little bit?
I was 16, so like I understood what was happening. I just didn't like
A lot. A lot. All right, so after discussing, thank you for sharing that. I think it's always good if you can like imagine a patient. I like to bring a patient into every room. That's why I do case studies, because I think that if you apply it to a person, it makes it more real. So after discussing renal replacement therapies with a healthcare provider and nurse, Ms. J is considering hemodialysis, which statement indicates that Ms. J needs additional teaching. So remember, when someone says she needs additional teaching, I'm looking for what kind of answer? The wrong answer. I will need surgery to create an access rate for hemodialysis. Is that true? I will be able to eat and drink what I want after I start dialysis. No. Else than no. Even after beginning hemodialysis, patients are still required to do the food restrictions, and protein, potassium, phosphorus, and sodium. All other patient statements indicate the appropriate understanding of hemodialysis, and she will have a temporary catheter placed so she can receive dialysis while awaiting the AV fistula maturation and installation. Okay, the RN is precepting the nurse orientation unit who is providing care for Mrs. J after her return from surgery to create a left forearm access for dialysis, which action by the orienting nurse requires that the preceptor intervene. What do you think? Read it again. Right, so 2, obtaining a blood pressure reading by placing the cuff on the right arm. Remember up here, she had it on her left, so that's okay. So don't get caught in the nose on the test. So that's okay. Drawing blood labs from the temporary dialysis line, that is no. So dialysis catheters are sacred. Even the ones in the neck and the ones in the fistulas. And I will tell you, in my career, I have been asked by doctors on codes to just push it through the line. I'm like, nope. What are you talking about? There's a line right there, just use it. I'll get yeah, that's not my scope. I know that I'm not doing that. I'm like, if you but no, never, ever will I use a vascular access device that's intended for dialysis or anything else. And you may be asked to, and you you're clear. Ms. J returns to the med surg unit after her first dialysis treatment. Assessment reveals all of these findings, which assessment finding necessitates immediate notification of the healthcare provider. So we're not happy about that weight gain, right? And this is all blood pressure. That's okay, we see that sometimes. But yeah, decreased level of consciousness, what am I worried about? I'm thinking this equilibrium, right? Like she's really in a tough state. So, yes, one side. Changes in level of consciousness during or after hemodialysis can signal dialysis disequilibrium syndrome, a life-threatening situation, requires early recognition and treatment with anticonvulsants. This should be immediately reported to the healthcare provider so that appropriate treatment can be prescribed. And expected after hemodialysis patients would decrease in weight and blood pressure. We know that because they're trying to get the weight off. And the blood pressure tends to lower with the removal of so much fluid. And a small amount of drainage is common after hemodialysis. So the spot in the center is not disturbed. All right. Ms. J is preparing for discharge, and the RN is supervising a student nurse who is teaching the patient about her discharge medications. For which statement by the student nurse will the RN intervene? Yeah, because what do we know about Epigen? It's IV or sub-Q, it's not PO. So, Sevelamer prevents your body from absorbing phosphorus, that's true. Take your folic acid after dialysis. We don't give any meds on dialysis day except for what? Before they go. I relinquish that. Before a patient goes to dialysis, I hold all their meds except for their insulin if I'm covering them for a meal. If their meal comes up and they have an order for a sliding scale insulin and the trays in front of them, I'm going to cover them for their insulin. And I'm not giving them insulin, they're going to do that. Also, if they're a hip patient or a spine surgery or a trauma patient that just happens to be a hemodialysis patient and they're in pain, I'm going to give them pain medicine before they go to dialysis too. So insulin, pain medicine. And the reason for that is because even though they'll get to dialysis and after a while the pain medicine is going to be pulled right out of them, I'm not going to send them uncomfortable. But the reason why we hold all the other meds is it will be taken out of their body with dialysis. So when they come back to the floor, I need to assess them. I'm not going to just randomly throw them all their blood pressure meds. I'm going to assess them because I know that their blood pressure may have dropped in dialysis. And I'm going to get orders from the doctor, but I will be giving them their regular meds. If they have like a daily aspirin, if they have a Colace and all that stuff, I'll give that. And then when does the Sevelamer, I'll give that when they come back. Because that way it won't be useless. But if I am questioning any other meds like blood pressure meds for safety, then I will hold on that. The Epigen alpha, quite often they will give in dialysis, just so you know. And then Ms. Jane asks the student nurse why the subcutaneous injection of Epigen is necessary, why is it best, what is the best response. It will help stimulate the direction of red blood cells to increase your red blood cell count. And then Ms. Jane's calcium level is low, but it's now just barely within the normal range of 9 to 10.5, which statement by Ms. Jane indicates you will need additional teaching. What's the one that we're going to call? I'm sorry. It will help stimulate the direction of red blood cells, that one we will call on. And then the one that is a need for additional teaching would be number 4. I will avoid dairy products, broccoli, and spinach when I eat. So clients with low calcium should be encouraged to eat dairy products, seafood, nuts, broccoli, and spinach, which are all good sources of dietary calcium. Any sources of protein should be of high value, like chicken, fish, and eggs. I changed the one that you had on your thing because you can be able to see this one too, but you guys need to know your high potassium foods. those typically are your citrus fruits, bananas, this one's not even as good as other, cantaloupe. Make sure you know they are potatoes, tomatoes. Potatoes with skin on are really high source of it. So make sure that you know what are your high potassium rich foods. And just like you should know what your low potassium foods are that you recommend for patients. Because these ones are better for them to have. And then also know your phosphorus foods and what are high and what are low. So you want to steer them to the correct kinds of foods that they can tolerate. It is very confusing, and don't be afraid to get a dietitian involved because it's a lot to relearn. Make sure, and this talks about how the lighter, like the ginger ales or light colored sodas have less phosphorus. But over here, I talk to you about beverages such as chocolate drinks, fat foods. Those are high in phosphorus. Watch over this one. Yeah, sure. I will re-upload this too. Yeah. That one? Yeah, I'll just read out the PowerPoint to you guys so you can see it. You're welcome. The other one, they're not always perfect, but they're a little bit better than the pictures. Okay. It's really complicated with the dietary restrictions, get dietary involved. This is a huge thing that I found for my father when he had gone shopping. We went through took everything, all the suits and everything out of his house, and I invited anybody that takes care of somebody. And so he said, I bought this. This is no salt, because I can't use salt. I gotta use something. And I looked at, and his numbers were going sky high. I had to go over and give him Caxley. The doctor's like, hey, your father's potassium 6.9 and then I'm like, can you try Caxley at home? He's like, all right. So I went over and I brought 2 doses of that, got from the pharmacy, and I'm like, Dad, what did you eat today? He goes, I didn't do nothing. I didn't do nothing bad. He goes, I bought this new stuff. Look at it. So honestly, they don't market things correctly. Like it says no salt, people think it's safe, and it has huge pure potassium in it. So that's how we found out about that. So Ms. J's recent potassium labs of 6, which Paula includes with the nurse suggests she eats. So just know what ones you would choose for her to have. What ones you think would be better. Right. So foods high in K, like bananas, orange, dry fruits, potatoes, avocados, kiwi, potatoes, green beans, baked beans are high. But the low ones, corn, squash, leafy vegetables, small leafy greens like asparagus, green beans, meat, milk, and eggs are better. And then just know your kidney transplant fees. If they're lucky enough to get one, it's limited. My feet got cut off there because I pushed your face over there. It improves survival rate, quality of life. It needs to be match specific. It can be a family member sometimes. If it's not match specific, you can have a graft post rejection and have chronic rejections. The important thing for you to know is that patients that go onto kidney transplant lists have to be counseled, and they need to agree to staying on the meds for the rest of their life. It's like foreigns, sometimes the glucocorticosteroids, and they don't like the effects of it. Risk complications of hypertension after kidney transplant, they have to monitor that. Also, you need to let patients know that when they get a kidney transplant, they may need to be on dialysis for a period of time. It doesn't just automatically flip the switch. So quite often they'll come back from the kidney transplant with a Foley in place for strict INO, and they'll often have to have dialysis for up to several months to make sure that that kidney is in. Okay. And then lastly, just to recognize those things that I talked to you about before, properly. And then know your definitions, guys. The key points that I talked to you about. I think I covered them all pretty clearly. If you ever have any specific questions for me, you can always email me. Just know that you guys, since I made you take years old, presents with your birthday clinic, complains of fever, chills, and sore throat for more than 48 hours. She's been nauseated. Due to the severity of her sore throat, she has been limiting her fluid intake, and now her assessment identifies dry mucous membranes, cracked lips, red throat with patches of white, temperature 128, pulse of 120, and blood pressure 120 over 72. The skin's also long and very dry. She's tired and has not been able to sleep well. So why is her heart rate elevated? She's probably dehydrated, fluid volume deficit. Why, what are your priorities to care for her at this time? What? I can't hear. What? Yeah, we want to check the temp, but what about the cause? How about we're gonna get a what test on her? That was my whole reason for the slide. I want you guys to recognize, check the cross track, right? Because you can get what? Nephritis. Will you ever not get cultured now? Right? You can hurt your kidneys and you can end up on dialysis. So yes, you will. So decrease time, decrease pulse, replace fluids, hydrate her. The number of blood cells stayed the same. I'm not worried about that, but dehydration is the most common reason to increase her urine-specific gravity. We want to get her hydrated. She's dry, and that will fix her because she's an AKI because of glomerular nephritis, because of her strep B infection that she's been dealing with after college, spreading to all of her friends. All right, you guys are really good in interacting. I want you guys to understand about going to startmercer.com. Have you done this before? So somebody put this together. You spent some time on it. It's like 19 questions. They're really good. If we had time to review together, but I think you guys can do that whole thing. You can do it again and again. Okay? I think it's a good way to use this. Okay? It has really good rationale. Yeah.